Hello everyone. In this video, we are going to study about the pharmacology of autonomic nervous system. As we all know, autonomic nervous system is made up of parasympathetic system and sympathetic system. Sympathetic system is also called as thoracolumbar outflow and parasympathetic system is also called as craniosacral outflow based on the location of the outflow of these nerves. So as we can see, the nerves coming out from the brain and the spinal cord are reaching a ganglion. So this is brain, spinal cord, and there are ganglion at locations. Both parasympathetic and sympathetic system, the outflow will reach a ganglion and then they'll reach the organs. So the nerve fibers which are before the ganglion are called as preganglionic fibers, and after the ganglion are called as postganglionic fibers. As we can see, the preganglionic fibers of the parasympathetic system are longer when compared to preganglionic fibers of sympathetic system. Whereas the postganglionic fibers of parasympathetic system are shorter and vice versa. So as we studied, preganglionic fibers are shorter in sympathetic system, whereas they are longer in parasympathetic system, and similarly their postganglionic fibers are longer in sympathetic system and shorter in parasympathetic system. After this, what we need to know, neurotransmitters secreted by all the preganglionic fibers are acetylcholine. So both sympathetic and parasympathetic systems preganglionic fibers secrete acetylcholine as a neurotransmitter, whereas the postganglionic fibers of parasympathetic system secrete acetylcholine, while the postganglionic fibers of sympathetic system secrete noradrenaline. So this is where the difference comes. So based on the postganglionic fibers, the system are named. In case of parasympathetic system, it is acetylcholine and hence it is called as cholinergic system, whereas postganglionic fibers of sympathetic system secrete noradrenaline and hence they are called as adrenergic system. Okay, so after this much basic understanding, we need to know there is only one exception to this. The postganglionic fibers of the sweat glands, even though they are belonging to sympathetic system, they secrete acetylcholine. So in fact, this is the only exception where the sympathetic system's postganglionic fibers secretes acetylcholine. After this, we'll start understanding the functions of sympathetic and parasympathetic system. As we all know, parasympathetic system depresses heart, whereas excites all other places. Like at bronchus, it causes constriction of the bronchus. In the GIT, it leads to increase in the peristalsis because of contraction of intestinal muscles, which leads to diarrhea. It leads to contraction of the urinary bladder, which increases the urine outflow. It increases the secretions by stimulating the glands, and by contraction of the pupillary muscles, it leads to constriction of the pupil called as meiosis. Whereas sympathetic system, it stimulates heart, that is increases the heart rate, whereas in all other places it depresses, that is it leads to dilation of the bronchus, it leads to decrease in the peristalsis, which in turn leads to constipation, it leads to relaxation of the bladder muscles causing decrease in the urinary outflow, it causes decrease in secretions by depressing the glands, and it leads to a relaxation of the pupillary muscles, which is called as mydriasis. So this is the function of sympathetic and parasympathetic system. After this, we'll start discussing about the cholinergic system, that is parasympathetic system. So before really starting with cholinergic system, we need to know the neurotransmitter of the cholinergic system, that is acetylcholine. We'll study how it is produced or manufactured in the body, and based on that, we will study the drugs which increase the parasympathetic activity and decrease the parasympathetic activity. So this video will be totally dedicated to parasympathetic system. Now, as we all know, this is a presynaptic neuron. We are looking at a picture of neuromuscular junction. This is a presynaptic neuron and this is a postsynaptic neuron. And acetylcholine is manufactured in the presynaptic neuron. So acetylcholine is taken up into the presynaptic neuron, and by acetylation it is converted into acetylcholine, and now this is stored in the vesicles and is released as and when the impulse is generated. So once this acetylcholine is released into the synapse or neuromuscular junction, it acts on the receptors present on the postsynaptic neuron. And once this action is brought about, it is degraded by an enzyme called as acetylcholine esterase. So these are the four main steps in the manufacturing of acetylcholine. So if we find out the drugs which can modify these steps, then we can control the action of parasympathetic system. The slowest step is the uptake of choline, that is the first step. Okay, so what are the drugs that decreases the parasympathetic activity? If we reduce the uptake of choline, we can reduce the parasympathetic activity, and one such drug which reduces the uptake of choline is hemicholine. Okay, hemicholine. So from the name, how we can remember it? It leads to uptake of half of the choline, that is hemicholine in EM. Okay, so half of the choline is uptaken, which leads to half of the acetylcholine manufacture. So because of that reason, there will be decreased acetylcholine and decreased parasympathetic activity. The second step being the acetylcholine being stored in the form of vesicles. If it is not stored in the form of vesicles, it cannot be used. Okay, so if the acetylcholine is not transported into the vesicle, one such drug is वेसामिकोल. वेसिकल में कोलिन नहीं आएगा. We can remember it this way. So if acetylcholine is not transported into the vesicle, there is no use of acetylcholine. So hence there is decreased acetylcholine and decreased parasympathetic activity. Okay. Now the third drug being the drug which decreases or inhibits the release of acetylcholine which is in the vesicles, and that drug is botulinum toxin. So this leads to inhibition of the release of acetylcholine, because of which there will be decrease in the parasympathetic activity. Now, can we increase the parasympathetic activity? Yes, and that is by controlling the fourth step of acetylcholine manufacture, that is the enzyme acetylcholine esterase. So as we all know, acetylcholine esterase degrades the acetylcholine. If acetylcholine esterase is blocked, there will be acetylcholine in the synapse, which will lead to increased activity of the acetylcholine. So the drug which blocks the acetylcholine esterase is the physostigmine. So hence there will be acetylcholine in the synapse for longer duration, which leads to increased parasympathetic activity. So these are the four main drugs which acts at this level of manufacturing of acetylcholine, which increases and decreases the parasympathetic activity. Now, after knowing about these manufacturing of the acetylcholine and the drugs which alter it, we will study about the receptors of the acetylcholine which are present on the postsynaptic neurons. Okay, so there are two types of receptors of acetylcholine basically. One being the nicotinic receptor, other one being the muscarinic receptor. So nicotinic receptors are of two types again, NN and NM. As the name suggests, nerve to nerve junction, that is called as ganglia. The neurons, the receptors present there are NN, and the neuromuscular junction is a nerve and the muscle, and hence it is represented as NM. So among these two receptors, NM require optimal stimulation, that is in both hyper and hypostimulation, muscle weakness will be there. Okay, in case of muscarinic receptors, they are of three types mainly: M1, M2 and M3. M1 is present in stomach, M2 is present in heart, and M3 in all other locations like bronchus, GIT, bladder, glands and pupil. So this can be remembered by पहले खाओ पियो फिर दिल लगाओ बाकी काम बाद में. Okay, so M1, M2, M3 are the three muscarinic receptors, NN and NM are the nicotinic receptors. After knowing about the receptors and acetylcholine manufacture, now we'll start with proper drugs which increase the parasympathetic activity and which decrease the parasympathetic activity. The drugs which increase the parasympathetic activity are called as parasympathomimetics. That is, it acts like the parasympathetic system and increases its activity. So this can be again classified as directly acting drugs and indirectly acting drugs. What are the directly acting drugs? These drugs directly act on the receptors to increase the parasympathetic activity. Whereas the drugs which are indirectly acting are by increasing the acetylcholine esterase enzyme. Okay. So starting with directly acting drugs. First one being pilocarpine. So the pilocarpine, as the name suggests, P for pupil. Okay, so this drug directly stimulates the receptor M3 which are present in the pupil, and as we know, parasympathetic system leads to constriction of the pupillary muscles which leads to meiosis, and this can be used in a condition called as angle closure glaucoma, where we have to cause meiosis so that the patient gets treated. Next drug being bethanicol. From the name itself, B for bladder. So this also acts on the receptor M3 present in the urinary bladder, which leads to contraction of the muscles of the urinary bladder, which increases the urinary outflow. So this can be used in treating the condition called as atonic bladder, where the bladder is unable to contract or the bladder has lost its tonicity. So in order to stimulate it, we give the drug bethanicol. Okay. Next, methacholine. M for myocardium. So this drug methacholine acts directly on the M2 receptors present on the heart, which leads to depression of the heart muscles or cardiac suppression. And this can be used to treat conditions like tachycardia and arrhythmia, where we need to decrease the heart rate or decrease the contraction of the heart. Now, coming to one more drug called as carbachol, which has a common action. There is no particular receptor which it acts on. It can act on both nicotinic receptor and muscarinic receptor, and it has maximum nicotinic action. Okay. Now, coming to one more specific drug called as cevimeline, which is a new drug which is known to stimulate M3 receptor, especially in the glands, which increases the secretion. So this can be used for conditions like dry mouth, which is called as xerostomia, which is seen in case of an autoimmune disease called as Sjogren syndrome, where all these glands get destroyed. So in this condition, we can give this drug cevimeline, which increases the glandular secretions, thereby treating dry mouth. So this was all about the drugs which directly act on the receptors or directly acting parasympathomimetics. Now, coming to indirectly acting parasympathomimetics, they are nothing but the acetylcholine esterase blockers. As we know, acetylcholine esterase degrades acetylcholine. If we block that, there will be increased acetylcholine, hence increased action, that is parasympathomimetic action. So now, starting with acetylcholine esterase blockers, they can be divided as reversible acetylcholine esterase blockers and irreversible acetylcholine esterase blockers. Again, these reversible acetylcholine esterase blockers can be lipid soluble drugs or water soluble drugs. Lipid soluble drugs include physostigmine, which we have studied earlier also, which was known to decrease the parasympathetic activity. Now, natural product, physostigmine. What is the difference between the physostigmine and neostigmine? Physostigmine is a natural product. So it is a tertiary amine, which means 3 atoms are attached to the nitrogen. It is a non-polar and non-ionized, lipid soluble, so it can cross the blood-brain barrier. Now we have to bring all our application of general pharmacology here. As we all knew, lipid soluble drugs are easily absorbed and they can cross the blood-brain barrier, and they are absorbed easily if they are non-polar and non-ionized. Since physostigmine is a non-polar, non-ionized and lipid soluble, it is absorbed easily, whereas neostigmine is a synthetic product which we have prepared. It is a quaternary amine, that means 4 atoms are attached to nitrogen, and it is a polar and ionized, so it is water soluble and it cannot cross the blood-brain barrier. Now we can make use of this also. Like if it does not cross the blood-brain barrier, it won't reach the brain and it won't lead to side effects of or central side effects. Okay, so what are the effects now on the GIT? Since physostigmine is oral, is lipid soluble, it can be given orally and it is absorbed through the intestine, whereas since it is water soluble, it should be given as injectable. Blood-brain barrier, since physostigmine can cross the blood-brain barrier, there will be central effects present, whereas neostigmine does not cross the blood-brain barrier, so no central effects will be there. On the pupil, it can act, but neostigmine has no effect on the pupil, whereas physostigmine, being the lipid soluble drug, it can act on the pupils and it is used in angle closure glaucoma. Now, what are the uses of lipid soluble drugs? Just we studied, it is used in glaucoma because it can act on pupil, and this is by physostigmine. Similarly, lipid soluble drugs like physostigmine can be used in atropine poisoning because atropine is a drug which is a muscarinic receptor blocker, which blocks M1, M2 and M3, and atropine can cross blood-brain barrier. So if we have to treat that poisoning, we will have to use a drug which can cross blood-brain barrier, and for that it should be lipid soluble. So drug of choice is physostigmine. Now, third condition where we can use physostigmine or lipid soluble drug is senile dementia or Alzheimer's disease. What happens in Alzheimer's disease? There is a nucleus called as basal nucleus of Maynard in our brain where acetylcholine is plenty. But if there is degeneration of these cholinergic neurons in basal nucleus of Maynard, there will be deficiency of this acetylcholine, which will lead to dementia, that is retaining memory. There will be problem with retaining memory. So in that condition, what we can do, since it is in brain, the drug which we give have to cross the blood-brain barrier, and for that physostigmine is the drug. But there will be peripheral side effects because of action of physostigmine on both like central nervous system and peripheral nervous system. Here we only need central nervous system action, but because of peripheral actions, there will be peripheral side effects. So hence physostigmine is not being used to treat Alzheimer's dementia, but there is a drug called as tacrine which is being used. But now again, this tacrine is also having disadvantages, like it is very short acting and it is hepatotoxic in nature. So now we have developed a separate drugs called as DRG drugs, which are donepezil, rivastigmine and galantamine. So these drugs are long acting non-hepatotoxic and hence are the drug of choice for Alzheimer's disease now. Okay. There is one more drug called as memantine, which acts by blocking NMDA receptors of the neurotransmitter called glutamate, which is excitatory neurotransmitters. So this is also being used for treatment of Alzheimer's disease. This was the uses of lipid soluble drugs, that is physostigmine. Now the water soluble drugs are neostigmine, which we studied earlier. There are two other drugs which are water soluble, that is pyridostigmine and edrophonium. All these three drugs are the water soluble reversible acetylcholinesterase blockers. Now what are the uses of these water soluble drugs? First use being the myasthenia gravis. So what exactly is a condition called as myasthenia gravis? Myasthenia gravis is an autoimmune disease where antibodies are produced against these NM receptors of acetylcholine. Okay, so because of this, the receptors are understimulated, which in turn lead to muscle weakness. There is one more condition called as cholinergic crisis, where acetylcholine is too much, is in excessive quantity, and because of which these NM receptors will be overstimulated, and again it will lead to muscle weakness, because as we studied earlier, NM receptors should be stimulated in particular should be optimally stimulated. If there is hyper or hypostimulation, then it will lead to muscle weakness. So the condition with which the patient will come to our clinic will be muscle weakness. Now it is our job to identify whether it is because of myasthenia gravis or it is because of cholinergic crisis. So in order to identify this cause of the muscle weakness, we do a test called as edrophonium test. Now this edrophonium is a drug which is water soluble acetylcholinesterase inhibitor. So what we'll do, we'll give IV edrophonium. Okay, since it is very short acting, that is its action is less than 10 minutes. So since it is very short acting, if the condition improves for 10 minutes, that is myasthenia gravis, since this edrophonium is a acetylcholinesterase blocker. So if this enzyme is blocked, there will be increase in acetylcholine, which means if the symptoms improve, there was actually deficiency of acetylcholine, and since we gave this drug, acetylcholine increased and symptoms improved. If it was due to cholinergic crisis, already there was too much acetylcholine, and now because of edrophonium, again we have increased acetylcholine. So hence symptoms will get worse. So on giving edrophonium, if the condition worsens, then it is cholinergic crisis. Since it is very short duration, that is for 10 minutes, we can identify the disease by basically doing a experimental test. This is not done nowadays, but just this is an application which can be done. Okay, so this test is called as edrophonium test. Now, how do we treat myasthenia gravis? Now we know that acetylcholine is deficient and we have to increase acetylcholine. That can be done by neostigmine or pyridostigmine. Since the acetylcholine is deficient in the peripheral system and not in the central nervous system, we don't need the drug which crosses blood-brain barrier. Hence, we will use neostigmine and pyridostigmine and not physostigmine. Okay. So, pyridostigmine is longer acting than neostigmine. Pyridostigmine and neostigmine both have additional direct NM receptor stimulating action. Okay. Basically, they are agonists of NM receptors and hence are best to be used in case of myasthenia gravis. So, what happens if there is increased acetylcholine? It will stimulate the NM receptors in the neuromuscular junction, so which will reduce the muscle weakness, but it will also stimulate these muscarinic receptors because acetylcholine can act on both nicotinic and muscarinic receptors. So now, because of these drugs which we gave, that is neostigmine and pyridostigmine, there will be stimulation of these muscarinic M1, M2, M3 receptors also, which will lead to side effects. What are those side effects? Now M1 is present in stomach, so because of which there will be increased acid secretion which will lead to acidity. M2 is in heart, so as we all know, there will be bradycardia or decreased heart rate, and M3 is in all other regions, like there will be increased urine outflow, there will be bronchoconstriction, there will be increased secretions, there will be diarrhea. So we have improved the muscle weakness, but the patient is using it in washroom because he is having severe increased urine outflow and diarrhea, because of which he will have to go and micturate or go and defecate every now and then. So if we have to treat this condition ideally, we will have to give a drug which increases the acetylcholine and which does not cause these side effects. In order to avoid these side effects, we will give the drugs neostigmine and atropine, because we studied atropine is a muscarinic blocker, that is M1, M2, M3 blocker. So on giving atropine, it will block these muscarinic receptors which will eliminate these side effects, because of which the patient will be having increased reduced muscle weakness and won't be having these side effects. Hence, in order to treat myasthenia gravis, we will be giving neostigmine along with atropine. Now, studying about the cobra bite. This is also a use of water soluble reversible acetylcholinesterase blocker. So what happens in a cobra bite? It is similar to myasthenia gravis, or basically the venom of the cobra will go and block the neuromuscular junction. So it is like neuromuscular blocker. Again, in order to release this neuromuscular blocking, we will give neostigmine and atropine, which is a treatment. Other condition being post-op paralytic LES. So again, after an operation or after muscle relaxant is given, there will be paralytic LES post-operatively. So in order to stimulate our gut, we will have to give a peripherally acting acetylcholinesterase blocker, that is neostigmine. Similarly, post-op urinary retention, again we will have to cause the contraction of the urinary bladder muscles peripherally, which is given by water-soluble drugs like neostigmine. Basically, water-soluble drugs are used in conditions where central nervous system action is not needed and only peripheral nervous system action is needed. Okay. After this, we'll study about a condition called as reversal of action of non-depolarizing muscle relaxants. Basically, atracurium and parencuronium like drugs which act by blocking the neuromuscular receptors. Basically, these are used during surgeries by anesthetists. Okay, we'll have to bring about muscle relaxation so that there is ease of surgery, and for that reason we use these drugs called as atracurium and parencuronium. Once the surgery is done, we will have to reverse the action of these muscle relaxants so that muscle contraction occurs, and for that reason we will have to cause or increase the acetylcholine, and this is done by drugs like neostigmine and pyridostigmine. Atropine should be given with neostigmine and pyridostigmine to stop the muscarinic side effects of acetylcholine. Same. So again, for reversing the action of non-depolarizing muscle relaxant, we will give pyridostigmine or neostigmine along with atropine. Okay, so this was about reversible acetylcholine esterase inhibitors. In summary, so reversible acetylcholine esterase blockers, this can be again classified as lipid soluble drugs and water soluble drugs. Lipid soluble drug being physostigmine, and this water soluble drugs being neostigmine, pyridostigmine and hydroforium. Now we have studied the uses also. So this was about reversible. There is one more category under this, that is irreversible acetylcholine esterase blockers. Basically these are indirectly acting parasympathomimetics. Okay, so what were the directly acting? We studied those 4 drugs: pilocarpine, bethanechol, methacholine, and carbachol. They were directly acting parasympathomimetics. So this is all the flow chart which we have discussed till now. Okay, now if we discuss about these irreversible acetylcholine esterase inhibitors, this chapter about parasympathetic system will almost be half done. After this, we will have to study about the parasympatholytics, which is the drugs which decrease the parasympathetic action. We'll go about it. Now, starting with irreversible acetylcholine esterase inhibitors. So, this includes drugs or compounds like organophosphates and carbamates. Basically, these are not drugs, these are poisons which are taken by farmers or anyone who can take these drugs. Okay, so this includes malathion, parathion, DFP, tabun, and sarin. All these drugs are all these compounds are organophosphates, whereas carbaryl and propoxur are belong to a compound called as carbamates. So these are irreversible acetylcholine esterase blockers. These are highly lipid soluble, okay, and hence they can cross intact skin also. So what exactly does this cause? As we have studied, it will block the acetylcholine esterase irreversibly, because of which there will be no degradation of the acetylcholine, and that will lead to severe increase in the acetylcholine. So what does this do acetylcholine? It will go and stimulate nicotinic and muscarinic receptors. Okay, so what happens if the muscarinic receptor is overstimulated, just like the side effects which we studied? M1 receptor will be overstimulated, leading to increased acid secretion. M2 receptor will be stimulated, leading to decreased heart rate and decrease in blood pressure. M3 receptors will be overstimulated, leading to contraction of the pupils, that is pinpoint pupil. There will be increased secretion, diarrhea, and urinary incontinence and bronchoconstriction. So basically, it is overstimulation of these receptors, muscarinic receptors, which is because of organophosphates or carbamates. If there is pinpoint pupil and increased secretions, then it is clear that there is poisoning, and that is leading to acetylcholine esterase inhibition. Okay, increase in heart rate and BP can also be seen rarely, because we studied only the side effects of these muscarinic receptors overstimulation. If these NN and NM is also overstimulated because of NN stimulation, which is present in a ganglia, there can be increase in the heart rate and blood pressure, and muscle weakness occurs usually due to NM receptor overstimulation also, just like in cholinergic crisis. Okay, so what are the causes of pinpoint pupil? Other causes, like one we studied is organophosphate poisoning and carbamate poisoning. Other one can be opioid poisoning, like morphine poisoning. Okay, other causes like pontine hemorrhage and phenol poisoning can also lead to pinpoint pupil. So these are the points which we need to know if we see a patient with pinpoint pupil. It can be because of 4 causes: 2O and 2P, that is organophosphate and carbamate poisoning and opioid poisoning, pontine hemorrhage, and phenol or carbolic acid poisoning. Okay, now how do we treat this organophosphate or carbamate poisoning? We know now M1 or muscarinic receptors is being overstimulated, and we know the drug which blocks the muscarinic receptors, that is atropine. So atropine is a drug of choice in this case of organophosphate poisoning and carbamate poisoning. Okay, this is given by IV route in every 5 minutes till signs of atropinization occur. Now, let's imagine a case scenario where a farmer, or suppose a 45-year-old farmer, has come to your clinic with conditions or with symptoms like increased secretions, vomiting, diarrhea, then increased urinary outflow, pinpoint pupil. Okay, his heart rate is less, decreased heart rate and decreased BP. Okay, their family suggests that he has consumed some poison or insecticide which has OP in its name. Okay, it is a organophosphate, clear case of organophosphate poisoning. Now, since we know this will go and stimulate the muscarinic receptors, we'll start atropine. Now, how will we get to know if the atropine we are giving is working? So that can be confirmed by conditions, or is called as signs of atropinization. So what are these signs? Whatever the condition or whatever the symptoms the patient was exhibiting, they will start to come down. And among that, what are the two main symptoms we look for is reduction in the secretions and mydriasis. Basically, the patient would have come with pinpoint pupil and increased secretions. If on giving atropine every 5 minutes once, if there is reduction in these secretions and if there is dilation of the pupils, then it is an indication that the patient has received sufficient amount of atropine, and we will stop giving IV atropine now. Okay, so these are the two most reliable and most common sign we see after administering atropine every 5 minutes. If these two signs are not there, if still there is increased secretions and if still there is pinpoint pupil, we will continue IV atropine every 5 minutes again. And heart rate should also increase gradually because of atropine. Okay, but if there is muscle weakness because of NM receptor stimulation, that can't be reversed by atropine. Okay, after this, so now we have just blocked the side effects of acetylcholine, right? Because of increased acetylcholine, there was side effects leading to increased muscarinic receptor stimulation. Now we have blocked that. We didn't treat the actual cause. Why is acetylcholine more? Because acetylcholine esterase is blocked. So now we will have to reactivate this blockage. Okay, those are the drugs which actually treat this condition. They are called as oximes. So these are acetylcholine esterase reactivators. For example, pralidoxime and diacetyl monoxime, that is PAM and DAM, you can say. These are not the drug of choice, but they are effective in OP poisoning only. Why is that? Why is these drugs not effective in carbamate poisoning? That we will discuss in a while. So just remember that OP and carbamate are different poisons. In case of OP poisoning, we can give atropine and PAM or DAM. That is, oximes can be given in OP poisoning, whereas in case of carbamate poisoning, only atropine is used and PAM or DAM is not effective. Okay, so why is it so? We'll study now. So what exactly happens normally in case of acetylcholine esterase? So suppose this is a acetylcholine esterase enzyme, okay, the bigger one. It has two sites basically, which is esteric site and anionic site. So acetylcholine binds to this esteric site and is broken, that is degraded. Reaction is so rapid that we can assume this site is never occupied. Okay, so what happens when a patient has consumed organophosphate? Instead of acetylcholine, this organophosphate will go and bind to the esteritic site. Now the acetylcholine cannot bind to this esteritic site, so it is not broken and it remains in the synapse and leads to increased muscarinic receptor stimulation. Thus, this acetylcholine esterase has been inhibited. Now, when we give oximes, what exactly happened? This oxime will go and bind to the anionic site. Okay, and it will form a bond with OP, which is binding at the esteric site. Now, this bond between OP and oxime is stronger than the bond between OP and esteritic site. Because of that reason, it will pull the OP from the esteric site so that esteric site becomes empty. Now, again, acetylcholine can go and bind to the esteric site, and hence acetylcholine esterase is reactivated. Okay, but in case of carbamate, what happens? Carbamates bind to both esteric and anionic site. For this reason, oxime has no place to go and bind at the anionic site. Hence, in case of carbamate poisoning, oximes cannot be used. Got it? So carbamate itself is going and occupying both the sides. Now the oximes cannot go and occupy this site, so that it can go and form a bond with this carbamate. Hence entire acetylcholine esterase is occupied, and in case of carbamate poisoning we cannot use oximes. So this is why carbamates, like oximes, are not effective in carbamate poisoning. So this was all about parasympathomimetics. Now starting with parasympatholytics. So basically these are the drugs which decreases the parasympathetic activity. Now we will study these drugs based on the receptors on which they act and their uses. Okay, as we know, M1 is present in stomach. Pehle khao piyo. That is, M1 is present in stomach. And the drugs which act on M1 receptors which lead to decrease in the parasympathetic action are pyrenzepine and telanzepine. What exactly might be the condition where we will have to decrease this M1, or where we will have to block this M1? It is peptic ulcer. If M1 is overstimulated, it can lead to increased acid secretion. If we block this M1, acid secretion will be reduced, leading to treatment of this peptic ulcer. So hence this pyrenzepine and telanzepine can be used in peptic ulcer. Note, what should we note? That as we know, atropine also blocks M1, right? But it is not used in peptic ulcer. Why? Because atropine will not only act on M1, but it will also act on M2, that is heart. It will lead to bradycardia, and M3, which is present in many other regions, which will cause delay in the gastric emptying because of like increased peristaltic movement. Okay, but if atropine is given, there will be decrease in the peristaltic movement, which will lead to gastric emptying delay. So because of which there will be delay in healing of the peptic ulcer also. So M1, pyrenzepine and telanzepine used for treatment of peptic ulcer. In heart, we know the receptor present is M2, and the drug acting on M2 is atropine. So what exactly does atropine done? It will block all the three muscarinic receptors, that is M1, M2 and M3. So since it blocks presynaptic M1, there will be initial bradycardia. Okay, but it also blocks presynaptic M2, which will cause tachycardia later. So it is used for treating conditions like bradycardia and AV block. Okay, basically once we give atropine, there will be initial decrease in the heart rate, but later it will lead to increase in heart rate. Okay, after this, starting with M3 receptors. M3 receptor at the bronchus is blocked by two drugs, mainly ipratropium and tiotropium. So these are M3 blockers at the bronchus. Why do we have to okay, basically what exactly is the action of parasympathetic system at the bronchus? It will cause bronchoconstriction. So if the patient is having asthma, or if he is having COPD, already there will be bronchoconstriction, and further bronchoconstriction will lead to problematic breathing. So we will have to block this bronchoconstriction, and for that we give ipratropium and tiotropium. Ipratropium is a fast acting bronchodilator, and it is non-selective drug, we can say. It blocks all the three receptors, M1, M2 and M3. Whereas tiotropium is a long acting, and it selectively blocks M1 and M3. So the treatment or uses of these M3 blockers can be just like I have mentioned before, bronchial asthma and COPD, where we have to stop bronchoconstriction. After that, bladder has M3 receptor. So what exactly does the parasympathetic system do? It leads to contraction of the bladder, and it causes increase in urinary outflow. Now if we have to decrease this urinary outflow, we will have to use these M3 blockers at the bladder, and the drugs can be remembered by the mnemonic soft bladder. If the bladder contracts, it will be hard, no? So we will have to soften it, and for that the drugs used are soft bladder, that is solifenacin, oxybutynin, flavoxate, tolterodine, trospium and darifenacin. So what are the uses of these drugs? If the bladder is overactive, if the bladder is already contracting too much, then we will have to reduce the contraction, and for that we can use these drugs. Or if there is detrusor instability, basically the muscle of the bladder is called as detrusor muscle, and if there is instability in this muscle, then we will have to go for M3 blocker, and these are the drugs. If there is urinary retention, then we will have to go for M3 blockers, which are these drugs. Okay, so basically M3 blockers of the bladder, that is soft bladder drugs, are used to treat overactive bladder, detrusor instability, or urinary retention. Okay, so study in detail about sulfafinazine, derifenazine. Basically, these are bladder selective, that is vesico-selective, whereas trospium has less CNS side effects and is primarily excreted by kidney. Hence, it is contraindicated in renal failure. In case of urinary retention, because these drugs also cause urinary retention, hence these are contraindicated in benign hyperplasia of prostate. Okay, also what are the side effects of these drugs? It causes dry mouth and CNS adverse side effects. Okay, after this, starting with M3 receptors present at the glands can be blocked by drugs like atropine and glycopyrrolate. Why will we have to block these receptors? If there is increased secretion, or in case where we have to reduce the secretions before surgery and all, so this is used as a pre-anesthetic medication, that is glycopyrrolate, so that there will be reduced chances of aspiration. But what are the side effects? Because of reduced secretions, there will be dryness, which is contraindicated in children. Also, there will be decreased sweating, because of which there will be fever and hyperthermia. Okay, so these are the side effects. Now, in eye, we have M3 receptors, which will lead to meiosis. Okay, parasympathetic activity at eye is basically causing constriction of the pupil, that is meiosis. If we block this M3 receptors, it will lead to dilation, which can be used for fundoscopy, refraction testing, etc. Basically, whenever we go for eye checkup, in order to visualize our what we can say, visualize better, and to find out the power of our eye, they do refraction testing. So for that reason, we will have to use these dilating drugs, which are atropine, homatropine, cyclopentolate, tropicamide. All these drugs will block the M3 receptors in the eye, causing dilation of the pupil. Okay, so in case of children, we will have to use a drug with maximum cycloplegic action for dilation, and that drug is atropine. Whereas in case of adults, we will use a short acting drug, that is about 4 to 6 hour acting, and that drug or that drop is called as tropicamide drop. So these basically cause dilation, that is mydriasis, which can be used for refraction testing and fundoscopy. Okay, what are the adverse effects of these drugs? They are contraindicated in ACG. Simple, pilocarpine and all were used to treat acute closure glaucoma, angle closure glaucoma, whereas these mydriatic drugs are contraindicated. They also lead to dilation, because of which there will be blurred vision, that is due to cycloplegia, and there will be loss of accommodation. Hence, if we go for refraction testing, after our testing is done, we can't come out and open our eyes in the sun, because there will be loss of accommodation. Our eyes won't be able to adjust to the more amount of light present outside. So that is a side effect of these mydriatic drugs. Okay, after that, CNS drugs, which basically reduce the parasympathetic activity. So in the CNS, what was the parasympathetic action? That we'll know. Okay, the drugs are hyoscine, that is scopolamine, which is used to treat motion sickness or prophylaxis. Basically, whenever a person is traveling, he'll start feeling nauseous or vomiting. That symptoms are called as motion sickness. And in order to treat that motion sickness, we will have to reduce this parasympathetic activity, and that is done by a drug called hyoscine. Other drugs like benhexol, benztropine, and piperidine, these are basically used to treat Parkinsonism, where these are drug-induced Parkinson's. Because as we know, in Parkinson's disease, there will be decrease in the dopaminergic neurons, which will lead to decrease in dopamine. And also we know that there will always be a balance between dopamine and acetylcholine. So in order to treat this, we will have to increase the dopamine or reduce the acetylcholine. This reducing of acetylcholine is basically by parasympatholytic action, and that is why we are studying this in this chapter. That is, if we reduce the amount of acetylcholine by giving these drugs, benhexol, benztropine, and these will act in the CNS. So in the CNS, if the acetylcholine is reduced, there will be balance between dopamine and acetylcholine again, and hence drug-induced Parkinsonism is treated. Okay. Other than this, there are certain miscellaneous concepts which we need to understand. So as we know, in the motion sickness, vestibular system will be activated, which will in turn lead to triggering of the chemotrigger zone, which causes vomiting in case of motion sickness. And for that, we studied the drug called as hyoscine, which will act on the CNS and block this CTZ, we can say. Okay. Similarly, at very high altitudes, what happens? There will be decrease in the oxygen, which will lead to hypoxia, and this is called as mountain sickness. So there is difference between motion sickness and mountain sickness. For motion sickness, we use the drug called as hyoscine, but for mountain sickness, the drug is called as acetazolamide, okay, which is a carbonic anhydrase inhibitor. It is discussed here just because we should not confuse between motion sickness and mountain sickness. Okay. Again, related to Parkinsonism, just like I explained before, there is always a balance between dopamine and acetylcholine. And in case of Parkinsonism, there will be degeneration of these dopaminergic neurons, which will lead to decrease in dopamine, and there will be disturbance between this balance, because of which, again, we will have to reduce acetylcholine also to ensure balance, and that is done by these drugs which act on CNS called as benzhexol, benztropine, and piperidine. Okay. Also, just recalling what we studied earlier in this class, in case of organophosphate and carbamide poisoning, the drug we use or the drug of choice is atropine. In case of atropa belladonna or datura poisoning, as the name suggests, these drugs are leading to atropine poisoning. If there is excessive atropine, then the drug of choice for that reversal action of atropine is physostigmine. Early mushroom poisoning is also similar to organophosphate and OP or carbamide poisoning, hence the drug of choice is atropine. Okay. So what is it? Why is it specifically early mushroom poisoning? We'll study now. So basically, mushroom poisoning is of two types: early mushroom poisoning and late mushroom poisoning. Early mushroom poisoning is caused by specific species of mushroom, that is Inocybe and Clitocybe. So these species will cause early mushroom poisoning, which are similar to OP poisoning. Hence, drug of choice is atropine. Whereas this late mushroom poisoning is caused by a specific group or specific species of mushroom called as Amanita group. Basically, these are also called as hallucinogenic mushroom, and these are similar to atropine poisoning. Like these species will release atropine. So this will lead to increased concentration of atropine, leading to all these muscarinic receptor blocking. So in order to activate these muscarinic receptors, we need a parasympathomimetic drug which can cross the blood-brain barrier. Hence, the drug of choice is again physostigmine, we can say, or it is basically purely symptomatic. So based on the symptoms, we'll treat this late mushroom poisoning. So this was all about parasympathetic system.